Thank you for the introduction. I work in King Fahd University Hospital in Al Khobar and associated with Imam Abdurrahman bin Faisal University in Dammam, Saudi Arabia. I would like to thank Professor Huwaida and Professor Maha Baheri for excellent arrangement of this. It's really an honor and pleasure to be talking to all of you. Now, I'm figuring out if there's any connection between the two or not, if there's any association. Now, when I was preparing for this talk a few days ago, I thought maybe it has become irrelevant already, because in Saudi Arabia and in the rest of the world, we were seeing cases to be less than 100 per day. But now when I talk to you in the past 2-3 days or a few days, we see the cases are rising again, 500 and more daily cases. So I don't think COVID-19 is going anywhere. I don't think it is becoming irrelevant yet. So we should all probably keep updating ourselves with this. Okay. So my outline of the talk is going to be COVID-19 related acute kidney injury, its incidence, etiology, and mortality associated with that. I will talk about the COVID-19 related glomerular diseases. That's the main topic. And then some frequently asked questions about COVID-19 and glomerulonephritis suggestions. First of all, so this is kind of a little old, maybe a 1.5 year old picture from COVID from KDIGO. It was showing 5 to about 29%. Now, this was at a time when initial case reports and case series were coming from mainly China, and they had reported cases to be less than acute kidney injury in COVID-19 to be less than even to be around 0%. However, when the rest of the world joined in and more case reports started coming, it was as high as even 30% or 35%. Definitely, majority of patients, so I would say about 20% patients require dialysis as well, and higher mortality. Now, out of these patients, about 63% had proteinuria and hematuria, and about 25% as well. Obviously, all of these patients have baseline comorbidities, including the cardiovascular disease, baseline chronic kidney disease, diabetes, and hypertension, and all, which all, of course, contribute to having acute kidney injury. So what about the in-hospital deaths or the mortality related to COVID-19? So obviously those patients who present with acute kidney injury, they have higher mortality, and those who have proteinuria and hematuria, they have higher mortality as well. And here we can see the level of proteinuria and hematuria would correlate with higher mortality overall. So this is work by Rebecca May from Arkansas, US, and it was basically a retrospective cohort study, which they combined all the biopsies that were done in COVID-19 acute kidney injury, and they tried to look at what were the causes of, or what were the results of those biopsies. It was kind of surprising to see that the collapsing glomerulonephritis, which is a variant of FSGS, as you guys know, was taking the main part of the causes of acute kidney injury here. And as we expected, the acute tubular injury, acute tubular necrosis was a major reason as well. And the others were crescentic GN, IgA, TMA, and the rest. This was mainly the reports from US, and then they included, expanded their report to add patients from India and Sweden as well. The main reason here, acute tubular injury, was the second one. Now, this is another report which is including the rest of the reports from rest of the studies from the rest of the world. And here, clearly, acute tubular injury in most of them were the main reason. And collapsing glomerulopathy, or FSGS, was the second most common. Now, obviously, all of this it shows that different backgrounds, different patients of different ethnical backgrounds, different racial backgrounds would have different presentation of or the reason for acute kidney injury in COVID-19. So these are the hypothesized mechanisms of acute kidney injury in COVID-19 mainly. So the main one, as I said, was acute tubular necrosis, which is as expected in any case of sepsis or infection. Volume depletion plus hemodynamic compromise were the main reasons for acute tubular injury. In addition, there was some immune dysregulation seen as well. And that immune dysregulation resulting in a few mechanism or changes causing other types of kidney injury. There was cytokine storm, endothelial injury, complement activation, and glomerular injury, all of them causing acute kidney injury there. So cytokine storm, and all these pathogenesis are kind of interlinked with each other. They all occur together in a patient who is sick with sepsis. And there were some reports of rhabdomyolysis and hypoxic injury as well, causing acute tubular necrosis, micro and macrovascular thrombosis, which was causing thrombosis, renal functions, TMA, and then the glomerular injury, mainly collapsing glomerulonephritis, and some reports of post-immune glomerulonephritis, anti-GBM, IgA nephropathy, and so on. So I will come to the frequently asked questions that are related to acute kidney injury and COVID-19. First of all, are patients with glomerular disease, they are more likely to get infected with COVID-19 or not? This was a retrospective case control a report from Korea. They looked at about 220,000 patients, or 220,000 individuals, I should say, underlying comorbidities and on the risk of infection and the severity of that infection. And glomerular disease was found to have increased risk of contacting COVID-19 compared to those who did not have glomerular disease. So patients who have underlying glomerular disease, they were at higher risk of getting infected with COVID-19. This was another one from International Registry of Glomerulonephritis patients, which included mainly patients from US, Europe, and Australia as well. They had reported about 120 patients who had glomerulonephritis as baseline, and then they got infected. About 40 patients had glomerulonephritis, and 80 were the controls. And this showed that the mortality was higher in patients who had glomerulonephritis. So the severity of infection itself is also high, and mortality is high if patient had baseline glomerulonephritis and got infected with COVID. And one of the risk factors here they showed was reduced albumin causing more mortality. The second question that comes to mind is, are patients with underlying glomerular disease at risk of having disease relapse if they contract COVID-19? So trigger a glomerular disease flare by inducing a hyperimmune response. I will come to more details of this in a little bit. There was a report of children having minimal change disease, mainly in Spain, and they had recurrent disease after getting infected with COVID-19, and it seemed to occur, and none of these developed severe disease, and all responded to glomerulonephritis, all responded to glucocorticoid therapy with no severe complications, as you would expect in any other minimal change disease child. And then there were some reports of IgA nephropathy as well after an infection, after COVID infection. This was a report of anti-glomerular basement membrane disease. Patient was known to have anti-GBM disease, and the last relapse was about 5 years before this presentation. This time the patient presented with shortness of breath, hypoxic, ground glass opacities on the chest, and then the renal biopsy had shown fibrinal necrosis, crescents, and linear deposition. Had a very severe disease, so required dialysis from the very beginning. She was treated with steroids, 1 dose of cyclophosphamide, 2 doses of rituximab, as well as 7 sessions of plasmapheresis. Although it saved patient's life, however, patient remained dialysis dependent even after all this treatment. And by the way, this time she was treated with all the aggressive immunosuppressions, and she was not treated with so many immunosuppression in the past. Another question is, what is the role of ACE2? This is an important question. ACE2 as a risk factor for kidney injury in COVID-19. So let me tell you the details of ACE2. Basically, it was touched upon yesterday also by Dr. Marwa. So angiotensin 1 actually gets converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 works on angiotensin 81 receptor, and it causes its effects of vasoconstriction, apoptosis, all the inflammatory effects, and fibrosis. Now, ACE2 converts angiotensin 2 to angiotensin 1,7 rather than letting it go to 81 receptor. So angiotensin 1,7, it acts on MAS receptor, activates MAS receptor, and it causes all the actions opposite to the actions of 81 receptor. So basically, there is vasodilation, there's decreased cell proliferation, there's anti-inflammatory effects, antioxidant effects. So now, in normal physiological circumstances, there has to be a balance between ACE and ACE2 to get all the proper functions going. SARS-CoV, what it does, it has a high affinity to ACE2 to enter the host cells. So it downregulates ACE2, and what happens is in angiotensin 2 get uninhibited, and it works on angiotensin 1 receptor and causes the inflammatory effects. And this mechanism probably provides the reason for studying recombinant soluble ACE2 for the treatment of severe COVID-19 infection. It's being tested, and hopefully we'll hear about it soon. Now, as I said, SARS-CoV have an affinity to ACE2 and it's a main entry point into the cells. ACE2 is found in the apical surface of proximal tubular cells on podocytes and mesangial cells. And this led to the hypothesis that acute kidney injury is mediated by direct viral invasion of tubular cells and podocytes. Now, this was done a very long time back, and it has shown the representation of ACE2 and ACE and comparison to nephrin in the kidneys of mice. And the immunofluorescence here showed ACE2 co-representing with nephrin in the glomerulus, whereas there was no merging between ACE and nephrin. Also in the tubular cells, ACE and ACE2 were co-merging, so tubular cells, and in the glomerulus, they did not coexist, ACE and fluorescence by immunogold labeled ACE2. It was found to be in the podocyte foot processes and the slit diaphragm, and ACE was found in the endothelial cells, and there were no ACE and ACE2 found in glomerular basement membrane. So this leads us to another question, whether there is a direct viral invasion into the cells as pathogenesis, as the reason for pathogenesis of acute kidney injury. This question came up because of a few case reports and series that were published in the very beginning. This is a very early report from China that had looked at 26 postmortem biopsies. And it had shown that there are some virus-like particles that were seen inside in the tubules and podocytes. There were some central round structures which had some spikes as well, so they were looking like viruses, typically viruses. And then later on, and basically these are structures which look like virus particles. There were some other reports as well showing the same virus-like particles, and this led to the hypothesis that probably there are many cells causing the damage. However, later on, more recently, so of course the histologies did not correlate with the COVID nucleoprotein antibody or the viral RNA. Severely investigated reports did not find the antibodies or the viral particles by immunohistochemistry in situ hybridization. or reports that are coming more recently have not found the viral particles. However, this is still a controversial topic and is still being investigated. Now, the more recent experts, they have said that this may be these particles that were thought to be viral particles. They may represent endocytosis with subsequent formation of intracytoplasmic microbes. In the cytoplasm, they get coated by clarithin, which gives them a corona-like appearance. And this was in a COVID-negative lupus nephritis patient who had similar particles. Few more details about specific glomerulopathologies. I will go quickly through them because there's a limitation of the time. FSGS and collapsing glomerulopathy. FSGS biological mechanisms can result in a specific pattern of injury on the kidney biopsy, but we don't know if those patients had a pre-existing secondary FSGS rather than a primary glomerular disease and proteinuria for those patients, which we don't have. Collapsing glomerulopathy, which is now known as COVAN, just as a HIVAN, this is called COVID-related, COVID-associated nephropathy. It is a distinct variant of FSGS. But what is more striking is all the reports that have been presented so far. They have almost exclusively African-American ancestry, that patients who present with these, and majority of them were tested positive for high-risk APOL1 gene alleles. And we know that these mutations are associated with high risk of kidney disease progression. And previously, same collapsing glomerulopathy has been associated with other infections, as we know, by HIV, CMV, EBV, and parvovirus B19. TRIs have been identified on biopsies in these patients as well. The more important thing is the characteristics of these collapsing glomerulopathy patients. And it's seen in this collection of reports, it was shown that about more than half of the patients, 58% of the patients, had required dialysis when they presented, and the renal outcome was not so good. 40% of them remained dialysis dependent and remained with heavy proteinuria, and average creatinine was about 3.3, so they never returned back to normal kidney function. What about anti-glomerular-based membrane disease? The hypothesis is that an environmental trigger is associated with this disease. There are anti-GBM clusters that have been noted during influenza outbreaks in the past as well. And it is possible that tissue destruction in the setting of infection exposes the basement membrane collagen antigen targets, triggering the formation of autoimmune antibodies that work against the GBM. So these are the reports that have been in the past. And this was a report from Northwest London, which showed a spike in the cases of anti-GBM. They reported 8 cases in the 6 months, which was unusual for them, and four of them had COVID IgM antibodies present in their serum. Thrombotic microangiopathy, it needs a bit of time. I'll probably go through this very quickly. COVID-19 basically causes a hypercoagulable state leading to TMA. I will not try to be an immunologist here, but I'll just tell you briefly. The SARS-CoV basically activates the classical and lectin pathway for complement activation, and it leads to C3 activation, which forms more C3 convertase, C3 to C3A and C3B. C3B goes and activates the alternate pathway as well, and it causes more C5 convertase, which gets cleaved into, and C5 gets cleaved into C5A, which recruits more leukocytes and causes inflammation, and C5b, which goes in on the endothelial membrane attack complex. It activates interleukin 8 and monocytes, chemoattractant protein 1, and E-selectin, and all of these recruit more neutrophils, more inflammatory cells, and gets them attached to the endothelial cell surface, and then gets them get them transferred through the endothelial cell. Once it is inside the cell, it releases more proteases, cytokines, and reactive oxygen species, causing all the inflammation that we always talk about. C5a, it causes exocytosis of 1 millibenefactor multimers, and with the thrombomodulin shedding, it causes activation of coagulation pathways and causes TMA as a result. So this was a very brief and quick review of why inflammation happens and why TMA happens in these patients. This is why eculizumab and ravulizumab have been thought of as possible treatment for COVID-19, because they bind to C5 and then they prevent cleavage of C5 into C5a and activation of membrane attack complex. Now, ANCA-associated vasculitis, there was this report which had, I will go through it very quickly. This was a crescentic porphyritic glomerulonephritis, and the patient was treated with pulse. Patient did not recover kidney function completely, but the baseline creatinine was 5.5, and patient was never dialyzed. Two more reports of an African-American patient and South Asian patient from US as well. They had MPO and PR3 positive vasculitis. They were treated with rituximab and glucocorticoids. The first patient who was African-American, he had more severe disease. He was on dialysis, and the other one did not. However, in 2 weeks after treatment, they had shown a significant decrease in the antibody titers in both patients. This is our hospital. What we have noticed here is from 2015 to 2019, roughly, we had about similar cases of glomerulonephritis, FSGS, lupus nephritis, and ANCA-vasculitis IgA nephropathy. However, in the last 2 years, 2020 and 2021, we have noticed there's definitely a spike of about double the cases of, especially of ANCA-vasculitis and lupus nephritis. Of course, I'm not saying that these patients were all COVID positive. However, there has to be a reason why we had a spike in this, whether they were patients who got infected and they were asymptomatic, so never detected to have COVID-19, or because of the vaccination, which we hear about, and have means to diagnose all the patients who presented this way. So I had 2 cases. I will probably skip through them. They were both vasculitis cases. One of them was with dialysis requiring acute kidney injury, creatinine of 7.5, post-immune vasculitis on the kidney biopsy, high PR3, and we didn't know what to do with it. Was treated with pulse steroids and cyclophosphamide. Unfortunately, she died within a week time with the respiratory failure. Second case was a gentleman took COVID positive. Creatinine was normal at that time. The reasons, and then within a week, his chest infiltrates recovered, his acute kidney injury recovered, and he went home with normal creatinine. This was a good result. So very quickly, the suggested management strategies, of course, they are not guidelines yet, but they have been suggested by all the guidelines, the KDIGO, the NICE guidelines, the US guidelines. All of them are suggesting some treatment that we can have. Basically, it's looking at your patient's the ability to raise an effective antiviral immune response. And what is the risk of COVID-19 complications in this patient? So it will basically, these characteristics, for example, their age more than 60 makes the patient have more complications of COVID-19, and probably this patient will not be able to mount a good immune response. And other characteristics like low GFR, having hypertension, diabetes, heart disease, all of them make the patient on this side of the curve. So RAS inhibitions, very quickly, initial concerns for potential harmful association between RAS inhibitor use and severity of infection. They were raised, however, further studies. So RAS blockers can be continued without any problems. And now it is included American College of Physicians and Renal Association, all guidelines, they are okay with using RAS. Immunosuppression basically is balancing the risks and the benefits of immunosuppression, because on one side, suppression of immune system reduces the ability to mount a host response and combat a virus. On the other hand, inflammatory response in COVID-19 is the major determinant of the severity of infection. So basically, we need to decide inhibit. I'll just take 2 more minutes. Inhibit mechanism of kidney injury and cytokine storm, and then use the same risk stratification. Suggested treatment management. So COVID and glomerulonephritis, we can divide them in 3: active de novo disease or relapsing disease, active disease but on maintenance phase, and a long-term remission and ongoing tapering of immunosuppression. And active de novo disease or relapsing disease, we can divide them in high risk versus low risk to decide how to treat this patient. The active disease patients who are at high risk, what are those patients? Mainly the patients who are presenting with RPGN, like lupus nephritis, ANCA-vasculitis, anti-GBM, IgA nephropathy with crescents, or severe nephrotic syndrome with low GFR and or complications. So the recommendation is to use standard care of immunosuppression. There is no consideration to that. What we can do is basically we can increase the intervals and postpone scheduled infusions if not needed. And if we are using MMF or CNIs, we can use lower possible doses. Plex, it may allow decreased doses of other immunosuppressions, so Plex probably can be considered. IVIG is an immune modulator. It's not an immunosuppressant, so it can be used, and it has shown decreased disease activity. The low risk patients, who are these patients who have normal GFR and membranous nephropathy, minimal change FSGS and all, for them, there's no need to urgently treat them with immunosuppression. We can delay them immunosuppression, and management with general measures is enough. Active disease, but maintenance phase, IV infusions can possibly switch to oral alternatives, like cyclophosphamide can be to oral to avoid patient presenting in the hospital. IV steroids can be changed to oral steroids. For long-term remission patients who we need to lower the immunosuppression dose to minimal possible to maintain remission. For those who have been in remission for more than 12 months, immediate cessation of azathioprine or MMF is recommended. Hydroxychloroquine and CNI are okay to use. And if such patients who they are suspected to have COVID or they are exposed, then anti-metabolites need to be held. Stress doses of steroids, we should not forget them. Efforts should focus on social distancing, minimizing patient visits to the hospital, encouraging the use of telemedicine, limiting blood draws, using home dipsticks for urine proteinuria, reserving kidney biopsies only in critical cases. And I thank you for that. I'm sorry for being late.